Alright, so for this video, we're going to talk about multiple myeloma. Now, as implied already, we could already see that myeloma means disease of the bone, right? So, multiple myeloma is a disease of the bone. And as you could see here, I've strategically drawn a crab. This is going to help us talk about the symptoms of multiple myeloma. So firstly, we're going to talk about old crab. Old just means old age. C actually stands for hypercalcemia. R actually stands for renal failure. A stands for anemia. And B stands for bone lesions or bone lytic lesions. So if we remember that, we will understand that this crab can help us remember what exactly multiple myeloma is. And there are certain presentations a person will have if they present with increased calcium or renal failure or anemia. And we'll get into that. So let's deal with the pathogenesis of this. So as we can see here, we have our bone marrow, our bone and our bone marrow. Now in the bone marrow, we have what we call hemopoietic stem cells. These are the basis for all the cells in the bone marrow. And we have a myeloid lineage and a lymphoid lineage. The one we're interested in is the lymphoid lineage. In the lymphoid lineage, there are the T cells and the B cells. And furthermore, we're interested in the B cells. In multiple myeloma, the B cell, there is a mutation which causes the B cell to proliferate out of control. So there's this proliferation of the B cell, loads of the B cell becomes proliferated. Usually, the division of the B and T cells are under strict control, but this mutation causes the B cells to keep on proliferating and dividing. So picture every one of these little red cells to be now a B cell, proliferating over and over, and using up all of the hemopoietic stem cells in the bone marrow, using it all up to produce this B cell. Now, a consequence of this is that none of these hemopoietic stem cells, none of these resources are left to produce red blood cells. So the person has anemia, and they'll present very tired and fatigued. Now the other consequence is that, remember, this B cell, if you remember from immunology, produces antibodies. And antibodies are proteins. Now there's some consequences of this which we will talk about next. So as you could probably guess, it has something to do with the kidneys. These antibodies, light chain and heavy chain antibodies, they are mostly of type IgG. And you know that we have IgE, IgA, IgM. This type is mostly of IgG in multiple myeloma. These antibodies deposit in the kidney tubules, as you can see where the green strokes are. They deposit in the kidney tubules and exert what we call tubulopathic effects on the kidneys. And this stops the kidneys from filtering the blood efficiently, giving the person acute renal failure. So if we were to do renal function tests on the patient, such as urea clearance, we would see that the blood urea would actually be way above level because the kidneys can't clear it, the kidneys can't filter it. So thus, these waste products are going to build up in the blood. Next, we'll address the C in crab, which is the hypercalcemia. Now in multiple myeloma, in normal bone, there's a balance between the osteoclasts. These are what break down bone, and the osteoblasts. These are what builds up bone. But in multiple myeloma, there's a mutation in a receptor complex called the RANKL receptor complex. And this causes hyperactivity of the osteoclasts, which break down bone. So they chew off bone, and chew off the calcium, and put it into the blood. So the blood is now loaded with calcium, a lot of calcium in the blood. And a person with hypercalcemia, well, they will present with one, it could be gastrointestinal difficulties such as constipation. They can also present with kidney stones, which would be pain, and it also affects psychiatric overtones, so they can be anxious or depressed. And this is how a person with hypercalcemia will present. Next, we'll discuss bone lesions. Now, it only makes sense that if loads of calcium is coming off of the bone, then the bone will become weaker. And what will happen is that we will see something called punched out lesions on an X-ray. It could be seen a lot in the spine and the skull, and also what happens is that because so much of the calcium is leached out, the bone becomes very weak in this area here and can cause pathological fractures because there is no stress on the bone. Pathological fractures. It's pathological because it wasn't broken from any trauma, just the weakening of the bone. So that was the pathogenesis. How do we diagnose multiple myeloma? Well, we could diagnose multiple myeloma with the WHO criteria. There are major criteria and there are minor criteria. The major criteria just says that there must be 30% or more bone marrow plasma cells, which is the B cells, urinary kappa or lambda chains, which is the antibodies, 1 gram in 24 hours, or more than 1 gram in 24 hours, serum IgG, which is what the B cell overproduces, greater or equal to 3.5 grams per deciliter, and a biopsy-proven plasmacytoma. There are also some minor criteria, which is like the same as the major but less so. Bone marrow plasma cells, only 10 or 30%. IgG present, but just less than 3.5, and as we spoke about, the bone lytic lesions. Now, to diagnose it, you need 1 major and 1 minor, or 3 major, which includes 1 to 2 here. Right? Now, what could we do? What investigations could we use to diagnose multiple myeloma? Well, first of all, we could use a blood film. Now, when you do a blood film, the major feature of multiple myeloma is something we call rouleau formation. Now, this rouleau formation, it will look like something like this. The red blood cells, these are red blood cells, they kind of clumped on top each other, forming like a little line. They sort of stuck to each other. And this is due to protein interactions. So this is a characteristic of multiple myeloma, rouleau formation. Next, we could do a bone marrow aspiration. This is where we actually inject the needle into the bone marrow, pull out bone marrow, and put it on a microscope slide for investigation under a microscope. So when we look at this, we will be able to see the proliferation of the B cells, and that could help us in determining if it's multiple myeloma. The next thing we could do is based on the fact that these B cells produce antibodies. So we can check the blood serum for antibodies by serum protein electrophoresis. Now, a normal serum protein electrophoresis is supposed to look like this. As you can see, it displays all the proteins in the blood. So you have albumin, the alpha 1, alpha 2 band, the beta, and the gamma over here. This is the one we're interested in, because since multiple myeloma B cells produce IgG, which is gamma, we want to look at this region here. This is how it looks in a normal person. This is how it looks in a multiple myeloma patient. We see that IgG is being so overproduced that it actually spikes up. This is known as a monoclonal gammopathy. And this is a very good indication that the patient may have multiple myeloma. It could also be monoclonal gammopathy of undetermined significance. So next, as you know by now, multiple myeloma is basically a cancer of the blood. So chemotherapy and stem cell transplant, where we could try to attempt to replace the bone marrow cells, treatments, or you could use the pharmacological or pharmaceutical treatment, where you could administer thalidomide. The mechanism of action is not fully known, but it's expected to work via its anti-angiogenic effects, and it also works via oxidative stress inducing effects. Bortezomib is a proteasome inhibitor of 26S mammalian proteasome, and it stops the protein function and expression of the cells, so there would not be proliferation. Tries to stop the proliferation, the expression. Okay, hope this helped.